So at this point, I'll just hand it over to Andrew Brun, who's the Vice President for VAADA, and I'll hand it over to Andrew. Over to you, Andrew.
Thanks so much, Sam. Welcome, everybody. I'm really pleased to be here before you as the VAADA Vice President. And I think we've got a really interesting, two interesting speakers and then a great panel for you today. Before we get started, I just wanted to acknowledge that wherever you are participating in this webinar today, that you are on Aboriginal land, and it always will be Aboriginal land. And as a non-Indigenous person, and on behalf of VAADA, I thank all elders past, present and emerging. I'd like to acknowledge all of the Aboriginal community members that might be joining us today. At a personal level, I just want to take this opportunity to thank Uncle Bootsy Thorpe, Uncle Pat Farrant and Auntie Deb Chaplin for sharing their wisdom and supporting me over the years and for keeping their communities strong. And I encourage everybody in the AOD sector and other sectors to build relationships with Aboriginal community controlled organisations, learn from them and keep working with them in the best interests of everyone in Victoria. Again, a pleasure to be able to make that acknowledgement on behalf of VAADA. There is a little bit of housekeeping before I introduce Argiri and Tom, and I need my glasses because I'm an old man these days. It's really that you'll have an opportunity to ask questions via the Q&A panel in this webinar. You'll find the icon at the bottom of your screen. We will not be monitoring the chat channel, but feel free to make comments there. If you do put forward a question, if someone puts forward a question that you think is important, you can upvote it by liking it. And without further ado, I'm going to go on to introduce our speakers. The first of our speakers will be someone I know very well, and I'm very pleased to introduce him. It's Argiri Alisandratos. Before I read out the formal bio, I just want to let everybody know that Argiri is a person in government that everyone in the youth sector can trust. He's particularly responsive. He holds the same values that we all hold in the sector. And he's just particularly great at holding those values, working with complexity and getting results. And now the formal reading is that Argiri is the Deputy Secretary, Children, Families, Communities and Disabilities at the Department of Health and Human Services. Argiri joined the department more than 26 years ago as a child protection practitioner. Since then, Argiri has held a number of senior leadership roles within the department, including Deputy Secretary South Division, Chief Operations Transformation Officer, Director Southern Melbourne Area, Director Inner Gippsland Area, Assistant Director Placement and Family Services in the Children, Youth and Families Division, and Manager Community Services Loddon Mallee Region. As Deputy Secretary, Argiri leads statewide policy and programs for children, families, communities and disabilities. This includes leading the major reform transformation of the state's child and family system under the Victorian government's Roadmap to Reform agenda, as well as the development of a quality and safety infrastructure for community services across Victoria. Argiri's extensive experience leading service delivery, performance and quality improvement across the geographic area of the southern eastern Victoria means that he is uniquely placed to drive this ambitious reform agenda. And it also means that he'll have something I think really interesting for our sector to come to terms with today. Argiri also holds a Bachelor of Social Work from Monash Uni and an Executive Master of Public Administration, Monash University. Secondly, another fantastic speaker is Tom Symondson. Tom's been the CEO of the Victorian Healthcare Association, the peak body for Victoria's public hospitals, and Community Services since 2015. Tom has more than 15 years' experience in public policy development and advocacy. Prior to moving to Australia in 2010, he enjoyed a career in English local government. Tom is a member of Victoria's Family Violence Steering Committee and was also previously on its Community Health Task Force. He is a board director of First State Super, one of Australia's largest member-owned superannuation funds, and is chair of the International Federation of Community Health Centres. So you won't be able to because we're all online, but I'd like to have you join with me in welcoming them, and I look forward to hearing their presentation. So Argiri, it's over to you.
Thank you, Andrew. And can I begin by acknowledging traditional owners of the land that we meet on today and pay respects to elders past and present and any that are with us today. Thank you, Sam. Thank you, Andrew, for that very kind, generous introduction. Makes me feel a little bit old when you go through that whole history. Nonetheless, I want to thank VAADA, Scott and the team for putting together today's session, which I'm really looking forward to. It's a great lineup that you've assembled today, and I'm definitely looking forward to staying around for the whole session, and particularly for the panel session with Simon, Molly, and Leanna later in the morning. I want to thank everyone who's tuned in, and it's an absolute pleasure to be here and to join all of you. I know you've previously heard from Minister Foley and Melissa Arduka from the department in these webinars, and it's great to be here to share some of my insights from a social and community services perspective. As Andrew mentioned, Tom is going to obviously join us from the Victorian Healthcare Association, and together we want to delve deeper into the topics that is of interest to you. I know that we are very much still adjusting to the digital formats that we are engaging with, but I'm really hoping that for this session we can make it as interactive as possible. And when Tom joins me, and hopefully through a bit of dialogue after our initial reflections, we can get into a more interactive process. So I'm looking forward to it very much. I really appreciate it. I might just begin with some broad reflections, which I've been, as many of us have been thinking quite a bit about. Many of our clients' needs, as all of you will know, span multiple government department agencies and service providers. People, as we all know, don't fit neatly into boxes, and nor should they, and nor do they fit neatly into funding lines. And individuals' unique circumstances and needs often mean they intersect with multiple service providers and service systems right across our environment. And as you are all no doubt aware, community services like the alcohol and other drugs, environment, child and family services, mental health, family violence, homelessness services, and other not-for-profit share many of the same clients and current barriers to service delivery in a COVID-19 world that we are very, very much in at the moment. So like all organisations in our space, along with the private sector, we've had to make some pretty substantial changes to the ways in which we are currently operating and have operated now for a number of months. And for the people that we serve, this pandemic, the virus and its associated public health restrictions has created additional risk factors and even exacerbated some of their vulnerability. You're all aware of the cautious easing of restrictions that is underway for things like visiting family, and friends, the staggered plan for a return to school, the resumption of community meetings and forums like Alcoholics Anonymous, whilst also adhering to the social distancing requirements and the limiting of assembly of 10 people, and the recently announced plans to slowly reopen businesses like cafes and restaurants. And for services like ours, which largely are delivered face-to-face, whilst we're still awaiting directions from the Premier and the Chief Health Officer about what the easing of restrictions and a return to the so-called normality looks like, we know that realistically it will be a new normal. Sorry, the video dropped off there, so hopefully it's on again. And realistically, we will be operating in a COVID-safe environment for some period of time. The easing of restrictions and the path to recovery will have different impacts for different organisations and the varying modes of service delivery. Everything from casework, outreach, home visitation, through to personal care and bed-based services like residential rehab will likely be impacted in terms of the way that we operate through a COVID-safe environment. With this in mind, I'd like to take the opportunity to speak a little bit about the DHHS resources that have been developed to support our community organisations. The overarching plan, which is the COVID-19 Community Services Sector Plan, and I know that for the AOD sector, there is specific guidance that is being developed in terms of our COVID-19 response for alcohol and drug services. These plans were developed very much in collaboration with the sectors and with the critical advice of the Chief Health Officer, and will continue to be updated as our situation evolves and changes to provide the most up-to-date guidance for service providers. With the spread of the virus slowing, and we've all done a terrific job at that, we are now currently in the process of developing advice and relevant templates to support workplaces to develop COVID-safe workplace plans, which will guide practice as more face-to-face delivery starts to resume. Developing COVID-safe workplace plans will be key to how we maintain service continuity, but undertake this in a manner that will ensure safety for our service users and safety for all our staff who are interacting and providing that critical support to those that rely on that support. As we have with the development of our current plans, we will engage closely with all our sectors in the development of those COVID-safe workplace advice, and with the support of VCOS and sector peaks like VAADA, will work to tailor their use within respective service settings. Importantly, this guidance will be informed with critical public health advice and take a risk-based approach in order that we can safely deliver critical services to the many people who rely on this support being provided across the breadth of our social and community services sectors. So more work that we are heavily doing to support that development of that guidance, and which you will be engaged in over the next period of time. I apologise that for some reason my video keeps clicking off automatically without me having to do anything on it. So I'll just monitor that and make sure that that we bring it back online when it does it. I want to talk a little bit about some of the government functions and the collaboration across the Victorian government. In our discussions with VAADA about today's session, the themes that came across strongly were the theme around collaboration, both within government and across sectors, and in post-coronavirus or coronavirus-safe environments, how we translate our learnings into practice improvements or different modes of working. To start, I want to briefly talk about the new government coordination functions. And I'm taking a little bit of a step back here because we know that for those who sit outside of government, these structures can be a bit of a mystery. Sometimes they can be a bit of a mystery to us as we seek to understand and make sense about how we effectively use our coordination elements to bring more connected activity across government. I think this is especially true at times like these, when in addition to state government departments, we have new structures like National Cabinet and the Victorian Government's Crisis Council of Cabinet, which is the key decision-making forum that the Premier has established for this period of time that we are in. To help the Victorian Government respond to this health emergency, 8 core missions and 2 enabling programs of work have been established. Of particular relevance to the work that we do in our environments across the social and community services sector, the Health Emergency Mission, which is led by the Department Secretary, Kim Peake, and obviously focused on the health elements of this emergency, of which it is profound in terms of the work that we have been able to undertake on behalf of our community, and you've seen the benefit of that work in guiding decision-making across government. The second one is the Continuity of Essential Services mission, and this is people-oriented, which is responsible for identifying, mitigating and responding to risks to the non-health, social and human service delivery and outcomes related to this crisis. We know that this is both a health crisis and it's an economic crisis, but it's also a social crisis. And of course, the delivery of those essential human services are critical to how we mitigate some of those. The other one is restoration of public services, which covers a whole range of essential services for people, including AOD services. Both of these missions are jointly led by the Secretaries of the Department of Justice and Community Safety and the Department of Education and Training. And these functions are responsible for planning what recovery will look like for all our sectors, and also for how we respond in a more connected way through the period of COVID that we will be in for some period of time still. In many ways, COVID-19 has changed the way that we deliver services, but it also has created opportunities. As we all have talked about from time to time, there's been no playbook for COVID-19, and we've all had to quickly change and adapt the ways that we work. I want to again echo that one of the unforeseen benefits of the current situation is the increased collaboration both across sectors and between organisations and government, and we've seen that right across our environment, and it is has delivered profound benefits to how we've connected our efforts and our responses. I've been absolutely astounded to see the breadth of innovation, the goodwill, the camaraderie that's been displayed right across the board, people rolling their sleeves up, people taking a solution focused approach to how we adapt to meet the needs of our service users. AOD, like other community sectors and health services, has rapidly utilised technology, including moving to online delivery and pivoting traditional models of service delivery. And it's not only client contact that's changed, it's other aspects of casework that has also changed as well, including conducting risk assessments and supervision in new ways, having the systems needed to support remote work like secure access and client database systems that support our work, or things that may seem simple, like how we secure critical information that people hold on behalf of others. Additionally, there are also the wellbeing responses that many organisations have introduced to respond to stress and fatigue for the people that deliver those services right across the board. The coronavirus has changed the way we work quite profoundly. It also provides us with an opportunity to reset some of our old ways of working and challenges us to consider how aspects of digital delivery may enhance our practice and enhance the service offerings that we are able to provide to our service users. Impacts of physical distancing and stay-at-home requirements have seen children and family sector adapt in ways that will be useful to maintain in the future. So, and some examples include greater collaboration across services, increased use of video technology in terms of how we deliver those services, which has meant that many more young people, and particularly our those that are more attuned to using video technology and social media, have equally engaged in more profound ways than we ever anticipated. And of course, a whole range of extra staffing that we have been able to put in place through the allocation of flexible funding, proactively responding to the needs of children in care, particularly for those that have been had to learn from home environments, which has been the current state prior to us resuming school-based delivery over the next few weeks. There's also been tremendous announcement of additional government investment across targeted areas, providing opportunities for us to make changes in the way we work and deliver services. And there's been some recent announcements of funding for specialist family services teams over the next 2 years, of which we are working closely with our sectors to really tailor the delivery of those, making use of flexible remote working opportunities and digital delivery of those services. Really important enhancements that we've been able to put in place. There's some workforce challenges and demand that I'll quickly touch on. And as you all know, research suggests that extended emergencies such as pandemics can be particularly detrimental to already vulnerable people. For clients of the AOD sector, this may mean higher rates of and increased harm caused by alcohol and drug use. And we will continue to work through these challenging times to meet this demand. Organisations delivering support to Victorians across AOD may need to recruit additional capacity to effectively and more safely deliver services, and government is absolutely thinking about the sort of capacity and demand challenges that we'll face over the period of time. Over the course of this conversation, I'm interested to hear how you are planning for increased demand and thinking about your workforce and organisational needs. Just in closing, the past few months obviously have required quite energetic and decisive leadership, and that we continue to be, this continues to be the case as we collectively plan the future of our sectors, not just immediate COVID safe planning, but beyond this period of time. We now have an opportunity to reimagine what we deliver with and for the people that use our services, and ultimately that what it will look like from here on. We have actually been on a reform journey for a number of years now. For example, I know in my own space across families and children and family violence, we're still bedding down 4 or 5 years of reform work on the back of Roadmap for Reform and the Royal Commission into Family Violence. I'm interested in now how we weave what we've learned about reform over that period of time and what we've achieved over the relatively short period of the few months through this COVID-19 to create a new tapestry for our service system. Imagine the opportunities if we are brave enough to take them, given what we've been able to learn over this short period of time. Before I pass over to Tom, I want to close by again thanking all of you and your organisations for everything you're doing during this extremely challenging period of time. I'll now pause and invite Tom to join in the conversation and get his reflections as well.
Thanks, Argiri. And thank you all for inviting me to participate in this event today. I'd also like to acknowledge traditional owners of the land that we are all meeting on, which may be across the entire state of Victoria, and pay my respects to elders past, present and emerging, and acknowledge any Aboriginal people who might be here with us in this event today. So I'm going to talk a little bit about the situation from the perspective of health providers. I'm the CEO of the Victorian Healthcare Association, which is the peak for our public hospitals and our community health services. If my internet is a little bit in and out, it's because I'm in Woodend in the Macedon Ranges and our internet's not good at the best of times, but we keep getting these storms. So I apologise, and someone can hopefully tell me on the notes if I've disappeared for any period of time, and then the comments I'm making make no sense whatsoever because you've missed half of it. So the situation at the moment, we used to talk about flattening the curve. The curve is comprehensively flattened. That does not mean that it won't come back, and we must not be complacent. We're seeing outbreaks still happening. An outbreak is considered anything more than one infection in the same place. So yesterday at Kyabram Hospital, we had 2 staff who were diagnosed with COVID, with coronavirus, and who had not been working since infectious, but worked in the aged care facility at that hospital. That is an outbreak. Obviously, we had the meatworks. We are still seeing those outbreaks, but the curve is flattened. The numbers are nowhere near what we thought they could be, or what we feared they could be at the beginning of this pandemic. So the situation 2 or 3 months ago looked very, very different. And if we just cast our minds back for a moment, at that time, it started off being something that everybody thought was a flash in the pan, or authorities were enormously overreacting. What do you mean we can't go on holidays? What do you mean we've got to spend 14 days self-quarantining? It's not even as bad as the flu, all of that kind of thing. That seems like ancient history now. We know that the virus itself is massively more infectious than the flu and has a much higher death rate, and is something to be very, very worried about. Then we moved into the kind of the panic stage, where we were very concerned we might become the next New York or the next Italy. And we started to plan for the absolute worst case scenario. So just to give you some statistics, we had somewhere on a normal day, the Victorian health system has somewhere in the region of 330 intensive care beds. I have been throughout this process a member of the very dystopian sounding health service pandemic leadership team, which decides in a very quick way, changes to practice and policy in the health system in response to COVID. And in the very early meetings of that group, we were being given modelling which said that instead of 330 ICU beds, we would need 10,000. There was talk of ICU specialised hospitals being built in the convention centre. You might have seen that mentioned in The Age a couple of months ago. As it has turned out, and at that point we wouldn't have had the ventilators. You know, the idea is you go into an ICU bed, you have a ventilator, and that is the thing that keeps you alive, because this is a respiratory illness that affects your ability to breathe. We weren't going to have anywhere near, if we could find 10,000 beds and the nurses and doctors to staff them, we weren't going to be able to find the numbers of ventilators we would have needed to support people in those beds. So that was where we started. Then the modelling fell maybe to more something around 3,000 or 4,000 at our peak that we would need. Last time I looked, we only had 2 or 3 people in ICU beds across the state, and 8 or 10 people who are hospitalised, but 2 or 3 people in ICU beds needing ventilators. So that's not what has transpired, but that is what we thought would happen. So what that led to was an incredibly frenzied period of planning, and planning for a significant worst. We had every health service in the state, and we have 82 acute health services in Victoria, producing pandemic plans. You know, we have pandemic plans in every hospital, but they tend not to be dusted off that often. We have flu plans, because we know flu comes every year, but people were having to update those pandemic plans very quickly and with limited guidance, because government was learning on the hop as well. We had to train thousands upon thousands of nurses, who all stepped up to the mark and volunteered to do this, by the way, they weren't compelled, trained thousands and thousands of nurses and doctors who don't work in intensive care to get ready for working in intensive care if we needed them to. So I know thousands of people have undertaken training run by the Alfred for services in rural areas, for people who work in urgent care, to get them up to speed for helping in the pandemic had we needed them to. So that is fantastic. It was a fantastic show of the sector really just doing what it needed to do in a very, very quick way. And we've seen, over the last couple of months, as things have started to look a little less bleak, and the curve has started to become managed and flattened, we've seen people getting into more of a habit of waiting for the crisis. Now, that's where we find ourselves today. Most services that have been stopped, they've either started back up partially and slowly, or they are still halted. Elective surgery, as an example, we stopped all elective surgery except very urgent elective surgery very early on in this process. So there are people who need hip replacements, there are people who need breast lumps checked, who have been waiting for that more than they should have needed to. We've now started to ramp that up again, but we're not back at full capacity. So we have a health system that is waiting for a crisis, but actually has more capacity at the moment than it would ever normally have, because so much normal activity has either been halted or has been restarted at a lower level. So that's where we find ourselves today. And in the community health sector, which is also part of the VHA's membership, we've seen an enormous change in the way services have been delivered. All face-to-face activity was halted. Most community health services either closed their physical facilities or limited access to them very, very severely. So you have seen most types of service delivery, which used to be face-to-face, now being delivered in completely different ways. And I'll come to that in a minute in terms of the opportunities and the risks that we see coming out of COVID. Now, the next bit I just termed the good, the bad, and the ugly of COVID, because I think there has been good, and it would be wrong to say that there is no opportunity coming out of the pandemic. It is obviously a terrible time, and people have suffered enormously, and sadly, many hundreds of thousands of people across the world have lost their lives, including 18 here in Victoria. But there has been some good. There has also been some bad, and there's been some downright ugly. So the good, flexibility of service delivery, seeing services that should always have been available virtually or remotely now and haven't been, because as you know, clinicians and service providers, we haven't been quick to move to those formats. They now are being provided virtually. If they can be, they are being. Even things, and particularly in my sector, very, very powerful clinician groups, doctors, nurses, who might have said in the past, pharmacists, who might have said absolutely impossible to provide that particular type of service virtually. Things like physiotherapy consults are being provided virtually, which you might not imagine is possible, but apparently it is. And now those things are being provided through telehealth. The federal government came to the party very early and said, we will fund telehealth as though it is face-to-face in many cases through the MBS, which is great. And it's one of those things we need to try and keep. We've seen flexibility of working, so we still have a gender pay gap. We still have less flexibility for women than for men. However hard we try to change that, we have really not budged the needle on that. But we have seen with the almost immediate move to flexible working that playing field could actually be leveled for the first time. And that's an incredibly positive outcome. Leveling of access and equity playing field, so the idea that you don't have to find your way to the facility to receive your service. We will provide it virtually to you where we didn't previously. That has given a level of equity and access to people who didn't previously have it, which is fantastic. Now, the bad on that exact point is that we have digital poverty in Victoria. We have people who don't have access to computers, good internet. We have particularly people who live in rural areas, might not have any internet at all. So we do have digital poverty, and we have to take that into account. Digital is not going to work for everybody, just like it's not going to work for every type of service. It's equally not going to work for every person. And of course, the lack of social connection and the impact that has had on people. And then there's the ugly, which is really the things that we all know are happening, and hopefully none of you on the call are experiencing, but many of your clients may well be. And those are things like increased rates of family violence. Imagine your abuser and you are forced to be in a confined space with your abuser for 9 or 10 weeks with your children present. the potential for that to lead to horrendous, horrific outcomes for those people is just terrifying, and we need to keep that right at the front of mind. And there has been support for specialist family violence providers, but we know that many people don't come forward and ask for that support at the best of times, and for those people these are very much not the best of times. And also we are very likely, and we're already seeing signs of this, to see increases in suicide, massive increases in low-level mental illness, anxiety, and the like, but also higher-level mental illness for people who cannot seek services or don't feel comfortable doing so digitally, because again, it doesn't work for everybody. So just to end, a couple of risks and a couple of opportunities. It was said that people keep saying it was Winston Churchill that said never waste a crisis. Apparently he is thought to have said that at the end of World War II about the formation of the UN, but nobody actually knows if he did. It was actually Rahm Emanuel in 2008 who was the chief of staff to Barack Obama about the global financial crisis. And he's just recently come out and said again, he then became the mayor of Chicago. He then came out recently and said again, we must not waste this crisis. This needs to be the last pandemic that leads to a financial depression. It won't be the last pandemic, sadly, but it needs to be the last one that causes the global economy to tank, as it has done. So we have some opportunities as well from this crisis. Maintaining telehealth where it makes sense. Getting the federal government and state funders and other funders to continue to see telehealth and virtual delivery as a legitimate way of delivering care where it makes sense, as well as allowing people to have face-to-face service provision where that makes sense and having a nice mix of the two. We need to maintain flexible working. We need to not say, okay, everybody's back to the office again, and if you're the one working from home, we don't think you're actually doing any work. You know, as if we're really honest, is what we all used to think. It's not the case. We've learnt that anybody from the CEO or the secretary to the receptionist can work very effectively at home. We need to maintain that, if not just for a gender equity reason, but because it's actually what people want, work-life balance. And the risks, we might forget all of this. 3 months after the pandemic, we might have lost all of these learnings. It actually takes quite a long time for the human mind to form habits as significant as these. And, you know, if people start to say, oh, thank God we can have face-to-face meetings again, so all meetings must now be face-to-face again, we will all be back in the office, all of our services will be delivered back in our facilities, even though we know right now that is not the right thing to do. And for me, that is one of the biggest risks. And the other risk, the last one that I'll mention, and then we'll, Argiri and I might have a bit of a conversation, is the partnerships that have been formed. You know, decisions have been made incredibly quickly during this process, and there's a risk there that we forget about things like co-design with clients, but there is, you know, some decisions which would have taken years to get made have been made in days. Partnerships between acute health services, community services, GPs, you know, child and family services have just kind of happened, which in the past we would have set up project groups, we would have spent months trying to secure funding for a project officer. It's just happened through this because it had to. So if that's one of the risks of losing that, it's also the opportunity that we may be able to keep it. So that's my comments. There aren't currently any questions on the list, so please ask us.
Well, not so fast, Tom. Not so fast. So if I may join you, Tom, Scott Drummond, Program Manager at VAADA. Thanks, Argiri, and thanks, Tom. Certainly, Argiri, Tom, and I had a chat late last week in preparing and thinking about today. So I might throw a question at you and we might have a little conversation. I'll also be facilitating the panel coming up. But if we can start a little bit more broadly. So social distancing and thinking about social distancing and the potential impact on the number of consumers or clients that can access community treatment, community health centres, hospitals or elsewhere. Is there an awareness of the capacity issues around that, infrastructure needs and workforce requirements, which will be impacting services? So thinking about ramping back up, how do you do that? How do you tell us about some of the thinking that's going on in your spaces around those?
I'm happy to kick it off, Tom. I think, you know, what I was talking about earlier on about how we develop those COVID safe plans are going to critically go to this issue. What will it look like for how we understand the social distancing requirements, apply that to service settings, particularly, bed-based vis-a-vis outreaching service, and there will be variations. So those sort of factors are very, very critical, Scott, to the plans that we'll put out to sectors about what that can look like with the information coming from our public health colleagues. And again, we don't have those finely tuned yet, but obviously thinking about the sort of critical distancing that we'll have to maintain, the delivery modalities that we'll have to take forward, tele-delivery, as Tom has said, the mixture of both tele-delivered services and physical services will have to be considered in that way. And we're going to have to be very, very attuned to how do we keep our workforce safe in order for them to be able to deliver those services to those people that require them, and do it within the requirements of those social distancing environments. So we're critically thinking about this as an example in our child protection services right now.
Just I'm struck by, if we're sick of Zoom meetings as staff and clinicians who work in the sector, I'm picking up, Argiri, on a point that you made right at the start, which I thought was interesting, which we sometimes forget, or we need not forget, that consumers are acting with multiple agencies and services. So we're sick of telehealth and Zoom meetings, and we're making contact with consumers via the phone or otherwise. They're doing it with other services as well.
Yeah, absolutely. And don't forget, Scott, we're sick of it because it is our primary mode, right? Like every bit of interaction back to back in my day is a Zoom or a Teams meeting. Now for consumers, yes, they're interacting either through tele or through tele-delivered, but they're not necessarily spending a whole day. That's not to understate the issue that poses for how we maintain connection, relationship, particularly where a lot of our service delivery activity is based on a relational approach to the way that we engage and form a relationship to then be able to provide the assistance. So that's going to be a challenge in terms of how we tackle that going forward. But interestingly, when talking about the youth segment of our population, those young people have really taken to it really, really well. They are very averse to interacting in digital formats, in social media. It's probably more challenging from a service deliverer perspective to try and get that sort of tuning into how you then engage and deliver those services, which we're all learning.
And I would say on that, the thing we've got to do is we've got to continue to challenge ourselves. At the moment, we don't have to challenge ourselves to do this because we have no choice.
Yeah.
As soon as it starts to become an option not to do it, we're really going to have to challenge ourselves. And I say this, yes, us in advocacy roles or in government roles or in management, but also our clinicians. And I know clinicians who are saying, I'm just waiting to be able to provide that thing face to face again. And I'm thinking, I'm so sorry, it's not going to happen. It doesn't make any sense for the client or the service user to have that delivered face to face. It only makes sense for you as the clinician, because that's how you like it. You like to be able to go to your rooms, away from your house, and you like people to wait for you when you're running late and, all that kind of stuff. It's just not going to happen because the market's going to have shifted. Yeah. So I think for us, it's yes, we have to be, at the beginning of this, one of the big challenges was we needed to stand up a whole heap of testing centres in GP clinics. And almost none of the GP clinics could safely host a testing centre because the rooms are small. There weren't one door for entrance and one door for exit. And if that's the case in private businesses that you would imagine might have a little bit more flexibility with money, GPs will tell you that's not true, but you might think that they did. In our public services, absolutely, that's a risk. So, we have to say, and this will not be the last pandemic. This will happen again. We had SARS, we had MERS, now we've had COVID. It will happen again. We have to change our way of operating. And this is a fantastic opportunity to do that in a way that really works for clients. Think about things like disability services, where the price provided by the NDIA, and we can all complain about that it's not enough and that they need to do more, but it's essentially based on a mobile workforce. It doesn't have enough fat in it to pay for physical places of work for people who are delivering services into people's home. Yet most providers, certainly providers who do disability services as a small proportion, rather than the whole, are still sitting people at rows of desks. They might only be in them 1 day a week. So we actually need to say, well, actually, we should already have moved to mobile workforce. This has forced us to do it. Let's stay there because that makes our services more sustainable and it's in the interests of the client.
And Scott, I reckon that there lies the challenge, right? There lies the challenge for organisations, for government as funders, and for our workforces, because all of us have to shift. All of us have to take the opportunity of what we've learned from this period of time and what we've pivoted it to really stop us from falling back to form, which is, you know, what Tom has described for many of our workforces are just you know, potentially waiting to just revert back to the way that we used to do things. And I guess the challenge for us is, let's stop us from doing that. Let's take the opportunity now from what we've learned and how we can pivot our delivery arrangements going forward and how we enable and support that.
So let me ask then, you know, somewhat more controversially, because I agree certainly around challenging ourselves in terms of service system design and what we've learned from that. But is there a risk or a concern that governments, for example, will use telehealth as a way of reducing funding to service systems because they no longer require the physical space? Is there a risk in that? So, go on, Tom. Off you go.
It's safer for me to comment on this than Argiri because he's government. Yeah,
that's all right. That's why I asked it.
But I'll have a go first. And you know, kind of there's a question on the Q&A that kind of relates to this, which is around, you know, it's all well and good with things like scripts where all you have to do is write a script and you've performed the intervention. But if you're providing physio digitally, do you know it's been effective? And I think this is part of the fight. Is what we've got to push for is the most effective means. So in some cases, through things like the NDIA and some types of aged care funding, you already are funded to provide services digitally, and we have chosen as a system not to do so. So they can't take any more money away because they've already done it. But in other areas, it's about whether it's effective. So if, you know, in answer to Chris's question here, if we haven't got evidence that virtual physio works at the moment, it's the only option, so that's kind of okay. And, you know, there'll be academics who will be, you know, wanting to hit me for saying that, you know, just the way it is. But in the future, we do have to, and universities have to get on board with this, and I think they already are. I'm seeing research coming out of some of the Melbourne-based universities already on this kind of thing. We need to start to do assessment of our modes exactly as we have always done, but put it into the home-based or the virtual settings. And if it isn't effective, actually we as sectors, whether it's the AOD sector or the health sector or all of us together, have to say, no, I'm sorry, government, we're not going to provide something that is not safe or is not effective. Yes, we could do that during COVID because it was that or nothing. But in the future, no, not going to do it because it's not right.
And Scott, the only other thing is, I agree with Tom's point. The only other thing that I would say is what governments are looking for is evidence-informed interventions, delivery arrangements. They are looking for ways that we can deliver more effective services. And of course, they're always looking for efficiency, but also the need for effective delivered services that are evidence-informed is a critical phase that we're in at the moment, evaluating what's worked, what hasn't worked, taking carriage of those things that have worked into our forward agenda, being able to really pivot our delivery environments to ones that are going to really hit the mark, meet the needs of our consumers right across the board.
Can I just, Scott, answer? There's a great question here from someone called Nigel about working from home. I'd just love to answer, or try and answer it, because I think this is a really important point.
Please.
He says that it costs money, and you know, he can claim it at tax time, and this is not tax advice, by the way, but the ATO has simplified how you claim for working from home. So do that, all of you, but I didn't advise you to because I'm not allowed to. And will there be an allowance from employers essentially to cover that? There's two things. Firstly, employers need to recognize that if this is to become the new normal, you know, people who are digitally poorer, you know, like some of my staff didn't have their own laptops, so I provided a laptop because there is no way they can do their work without it, and that is just something that I have to do. So we have to recognize that for some people there is a prohibitive cost in delivering work from their own home. Yep. Employers also need to remember that there is a cost to the employer, because your duty of care extends to that person working in their home. And if they trip over something on the way to the kitchen, you might, as an employer, be liable. So you've got to recognise that there are additional costs. In the future, however, those might be offset by not needing as much office space. You know, I very annoyingly in February signed a contract for the VHA offices for another 7 years, right in the middle of the city, with more floor space than we previously had, which is now starting to look like a bloody stupid decision. But people will be going through, and I've got to work out what the hell to do with it, and we'll probably turn it into a collaboration space and have people able to drop in and work there when they wish to do face-to-face activity, but spend the rest of their time at home. And we will have to recognise that in the way that we remunerate people. But I don't know about all of you. I'm spending, when I travel to work, I'm spending $100 a week on the V-line from Wood End. I'm buying way more coffees. I'm buying way more lunch, you know, out. All of those kinds of things have to be offset. So whilst I agree, Nigel, it does potentially cost you more, we have to think of it holistically, because on the whole, it might not.
Yeah, but it's fair to say, Tom, that these are all things that we're going to have to work through. So your point rightly made is we've been forced into working in a particular environment. So we've had to do it. But now as we come out and think about what do the easing of restrictions mean for how we resume some more face-to-face modalities, and in my mind, we are going to be in a hybrid environment of delivering both remote and office-based. What does that mean for both costs? What does it mean for efficiency? What does it mean for effectiveness? What does it mean, as Jill asks, around the sort of choice that people have about how they want to receive those services, and particularly for how we reach into rural communities? And you know, there's a choice issue there, but also I think what we've now seen is that we've created more choice in some ways because of the digital delivery that may not have been there or been used in previous times. And again, your point about digital poverty has to be one that we have to think about. How do we make sure that people have the right technology, the right capacity, the right infrastructure to engage in these modes of delivery? That all has to be part of the consideration going forward.
Yep. We've essentially created choice for the people. We've been trying to create choice for decades. Through we get no credit for it because we had no choice. But I think where we do get credit, and there's another comment down here from Daryl, which says that, you know, the information sharing has been outstanding. The way people have come to the table on partnership has been outstanding. And if we can just remind, you know, we've now got this shared experience. There's a wonderful thing about shared experiences. In 5 years, we will all, it'll be like, where were you when JFK was shot? You know, I wasn't born, by the way, but you will all be able to point back to this time and say, now hang on, don't tell me we can't do that, because we all did it during COVID. And those kind of barriers should be able to be jointly kind of pushed aside if we're not the ones who've forgotten.
Well, careful what you ask for, because I'm going to hold on to that phrase, Tom, and remind DHHS in future that we were able to do it. What I might do is move to invite our panelists to join us, and thank Tom and Argiri, sorry. If you're happy to stay in the background, you know, we would welcome that. But what I'd like to do is move a little bit towards the AOD sector specifically, and thinking about the points that you've raised and how the AOD sector understands and interprets those, and what we're doing, and how some of our services are planning for that period post-COVID. So if I could invite Leanna, hi, thanks for joining us. Molly and Simon, really appreciate that. So I'll keep going if I may, and I'll introduce you. And thanks, Tom and Argiri. I really think that was excellent. I really value your input, and so stick around. Leanna, thank you for joining us. Leanna Helquist is the AOD and Homelessness Cluster Leader at CoHealth. Her operational and strategic role oversees CoHealth's harm reduction and community treatment services in the inner northwest of Melbourne. She is interested in quality improvement, strategic and change management, clinical governance, and working with stakeholders to provide best care every time. And Leanna is also a qualified dietitian with a Masters of Public Health. Simon, thank you for joining us. Simon is the CEO of Thorne Harbour Health, known to all of you, I'm sure. He has more than 25 25 years of experience working in and around AOD services, both in treatment and harm reduction, including 10 years as a VAADA board member, in fact. Formerly, the Victorian AIDS Council, VAC, Thorne Harbour is Australia's oldest HIV/AIDS organisation, provides a range of HIV and LGBTI health services across Victoria and South Australia. And Molly too will be known to us, I'm sure. Molly has a long and established career in the AOD sector in Victoria, having started out as a clinician, progressing through management to senior executive roles. She has worked in AOD services in a range of settings across acute, community and primary health settings, and standalone specialist AOD services. Molly holds representational roles on key government and non-government structures, including leadership roles in network development. With a background in nursing, psychology and social sciences, and experience and practice spanning the continuum of harm reduction through treatment. And in her current role is the ED of Withdrawal and Community Services at Windana. So we have a highly qualified panel to pick up first on some of Tom and Argiri's points. Can I ask you to kick us off? Anything strike you about what Tom and Argiri were offering, and would you like to make a comment on that?
I'm happy to start. I think we've learnt a lot. We moved very, very quickly. We've taken a lot of risks. We've done incredibly well as a country and as a sector. And I hear bureaucrats saying, well, we don't want to lose telehealth. We've now got to cross the line. And I think there's definitely groups who benefit from telehealth, people who are rural and remote, people with disabilities where communication's an issue, where telehealth makes it easier. But the push to telehealth is essentially about efficiency. It's not about effectiveness, from what I see. Most consumers don't want telehealth. They choose telehealth because there's no local service, or because there's no home-based care and GPs don't come to your home in Australia, or there's no public transport opportunities, or they're poor, or there's a whole range of other reasons. And it's because we, have large levels of poverty and inequitable access to health and postcode-based healthcare that people choose telehealth. On our waiting lists, half of our waiting list disappeared as soon as we went to these options, and they're now coming back because they don't see any other option in the near future. And their preference would always be to have face-to-face care. And yes, there was talk about partnerships forming quickly and work moving very fast. But as an organisation that works with an LGBTI community, and we are always one of the last groups ever consulted, we've seen decisions made with very little consultation, with very little engagement. A lot of money has flowed into very large organisations. Bigger has become better. Big dollars have gone into the big players, with very little thought about how marginalised communities get serviced. So groups like the ones I work with get very little attention paid to us. We tend to be an afterthought. We have a commissioner in there fighting for us in Victoria, but they are struggling in what they're achieving. And I think, and part of the issue about what's occurred, and it's occurred very quickly and everyone's had to adapt, and it's happening at a time when the Department of Health were changing themselves and shedding staffing. But this is not the first time we've been in crisis in this state. We had Black Saturday, we had periods, other crises that have occurred. And it just shocks me that constantly, despite these ongoing crises, these black swan events that occur regularly, that there's no one in the department to ever answer questions. There is still no advice in this country on casual sex and COVID. There is no advice from any government. There is no advice to whether you can work as an escort in this country around COVID. Despite questions going up, answers don't come down. No one knows who to send the questions to. Workers are being shipped off to focus on COVID, and I understand why that's the case. But to get your basic day-to-day work done, the shedding of activity in the department means that the department basically collapses on your regular work and then on specific questions that you've got. So I think, larger organisations do well because they have the capacity and the flexibility to move quickly and to put people onto these projects. But smaller marginalised groups do less well. And it just continually surprises me that we haven't worked out a way to manage a crisis and still manage functioning. All that said, there are definitely benefits and things that we can learn from this, and we will be better prepared next time because this will be cyclical and we will go back into lockdown sometime in the next 6 to 12 months.
Thanks, Simon. Leanna, would you like to make a comment on that? Yeah.
Yeah, I agree with Simon, but I guess my experience is that telehealth does work for some. We use telehealth across our agency and it is working for some groups. However, I also pick up your point that, you know, for our vulnerable people who don't have mobile phones or don't have connection, can't charge their phone, it really doesn't work too. So, and I think what in this conversation, you know, we talk about, you know, digital poverty, but you know, we work with vulnerable people that still need a choice of service. So, you know, with the telehealth, there is more choice now and options, but we still need to deliver a face-to-face service for some groups in our community, and really how that looks like in a COVID-safe way. That's something that I'm really interested in kind of considering. Undertaking telehealth, you know, for people, you know, that need that relational, need the material aid, need, you know, to feel included is really important. And I think the other thing that I think about is that we're not really talking too much about social connection. You know, we've kind of closed our kind of doors on our kind of social connectedness programs. You know, we've closed our recreation programs, and that's okay for a little while, but you know, in the future, and how you know, this is going to be around for a long time, but how do we keep people safe in a kind of a social connectedness way? And then this kind of impacts on, you know, other parts of their lives as well. So I'm not sure that there's an easy answer either, but this is something I think we need to start having more of a conversation about how we do that.
So in part, I hear the point being that the consumer or client group is not homogenous, and in fact, there's consumers that are more at risk, more vulnerable, or groups such as the LGBTI community who don't get the services or the attention that they need. Tom or Argiri, do you want to make a comment on that?
Yeah, I'm happy to, Scott. So I, you know, whilst I recognise some of the points that Simon makes about, you know, have we got to every member of our community, every group that is facing some particular challenges? Possibly not, but has government pivoted really quickly to identify those cohorts within our community that require additional support through this period of time? I would say absolutely. Like if you think about the announcements, and you know, again, I take the point about where the funding flows, but in terms of the significant level of investment the government has focused on those highly disadvantaged, vulnerable groups across our community, there's been you know, an enormous amount of pivoting and investment that is being directed to those systems of support for those people. So I think given the circumstances, and probably the other thing I would say, Scott, is that whilst we've had lots of crises, I don't think in my time, certainly, we've ever had this level of unprecedented both health, economic and social crisis. And we, as I said at the earliest part of my presentation, we really haven't had a playbook for this. And we've had to quickly pivot and learn. And yes, Tom's right, we've had pandemic plans and all of them, but really, unless you get them tested in the way that we've been tested, and we have been tested in incredible ways, and to see where we are today compared to where we could have been and where other countries have got to, I think that's a testament to how quickly we've been all able to adapt. And it's not perfect by any stretch of the imagination, but I think we've done reasonably well both to respond to the health challenges and also start to pivot to those economic and social challenges as well, and provide support to people. Lots of work still to do.
And the only thing I would say is I want us to be really careful of statements such as most people. So I don't think most people necessarily, if we take the whole population, do prefer to sit in a waiting room 4 hours on end. You know, say it's something like a GP service. I don't think most people are particularly happy with the way we used to provide those services face to face. And whilst they might prefer something that is more tangible and they have that human connection, if you give them the choice, they might actually choose something different. Now, if we're talking about people who have limited social connection, people who are incredibly vulnerable, people who need a kind of service that just should not be delivered virtually, or if it can be at all, then that's kind of a different conversation. I think it's fair to say that for a lot of people who are now receiving services virtually, that may well end up being their preference. And the risk is that we will say, you know, well, I don't really like talking to people over Zoom, so I would like to go back to something face-to-face. So we'll go back to the old way of doing face-to-face. So my caution is not to say, oh, everything should stay digital if it can, because I agree with Simon. It is very easy for governments to go, well, that's an efficiency drive and we like it this way, it's cheaper, and we'll cut your funding by 20% to cater for it. But if we go back to the old idea of it's face-to-face, but at our choosing as service providers in the way we want to provide it, in the paternalistic kind of patient-centered, which means a patient standing in the middle of a bunch of clever people who say, you need this, do what I say, because I have a degree and you don't. You know, if we go back to that, then let's stay with telehealth. But I suppose I agree and disagree, if that makes that probably.
Yeah. I think your point, Tom, here is choice is going to be absolutely critical. How we create that, how we create hybrid models and give people choice is going to be the way that we need to sort of be thinking about it in the longer term. It's not one or the other, and it's not about reverting back to the way that we just used to do it in a single sort of focused approach. I think we have to create more choice for people.
Would anyone like to make? I want to move towards workforce a little bit.
Can I just jump in there, Scott? Though, because I didn't. You know, I didn't say telehealth's completely bad, but, you know, comparing telehealth to waiting in a waiting room for 4 hours, you know, it's bad option A compared to possibly bad option B. You know, we should be looking for what is the better options here and trying to tackle those other areas, you know, that can make things better, and talking to consumers about what is your preference. No one wants to wait for 4 hours, and a lot of people also don't want a service on the phone. You know, there are other ways to let people know, you know, to send people a message to say your doctor's running 2 hours behind, come in 2 hours time, and to not have an elderly person walking 15 minutes late and say you've missed your appointment, you're now going to have to leave and ring up and make another appointment. You know, there's a whole range of areas, and particularly the elderly, people with intellectual disabilities, brain injuries, people who don't speak English, you know, these are not great options.
Yep. Molly, can I invite you to say something?
I'm actually very interested in just bringing it back to AOD services specifically. Argiri's comments around the COVID-safe work plans as we move forward into a COVID-safe environment. And in relation to Windana, which has a mixture of residential rehabilitation services, adult residential withdrawal and youth withdrawal services, I'm interested in some guidance and leadership around where we're going in terms of occupancy rates in our residential services, for example, in the next 3 to 6 months. You know, what will that look like? What kind of infrastructure support might we need? What are some of the other resources and supports we may need to maintain a level of service delivery so that people can access services? The other idea that we're thinking about is the development of a secondary workforce, because with residential services, if people go out or they're out sick, we need a backup workforce, which we currently don't have. So we're doing planning around those issues, as well as looking at the modelling around hybrid models for our community-based services. We're using both telehealth, digital platforms, and looking at a percentage of face-to-face services. But I am very interested in what's over the horizon and what we're not receiving any information around modelling and what the modelling is telling the government. So in the absence of that sort of information, it's very difficult to plan for the long term. That would be one.
Scott, I'm happy to jump in on
Thank
that.
you. Yep, sure.
Particularly around the COVID safe plans. I think, Molly, what we're keen on doing is engaging with sectors to take, as I said earlier, a risk-based approach to it. So there's a framework that's being developed. It'll ask a series of questions that are informed by public health policy settings at the moment. You'll be able to go through that sort of structured process to then be able to come out with some concrete plan around what it looks like for the service type that you're offering. And it will look different for bed-based services than it does look like for outreach services. And it will consider the sort of spacing requirements that you have to manage within your facility. And then obviously it will have an implication based on that spacing requirement about how many beds and how many services you can run through your current facilities. So that will then require a conversation with the funding body about what that means for you to be able to deliver in a COVID safe environment. And if that means a reduction of delivery targets because the physical environment can only mean that you're able to deliver 50% just using a number of what you currently deliver, then obviously that has to be a process of engagement with your funding body to be able to work that through. It creates some other challenges, of course, because then there's a flow-on demand impact if we're not able to deliver the range of services, and we'll have to get creative about how we attend to that sort of challenge. But again, we are very, very keen to engage with each of our sectors to really fine-tune those plans and to tailor them to the service offerings that each of our sectors have.
Well, I'm aware that some services are really not, and service spaces aren't fit for purpose exactly now. Leanna?
Yeah, I think we definitely, I think I get the point that we're making in terms of we really need to look at kind of workforce and how that's linked to services and how we can maximise both opportunities there to kind of make sure access is really good. I know for us, we're looking at things like cohorting, where we're staggering, service providers coming in on certain days, offering different types of appointment types or times. So instead of the o'clock, maybe the 15:15 or the 50:30 kind of appointments, looking at ways we can minimise how many people in the waiting rooms and things. We're also doing what we're calling internally, we've got an opportunity at one of our services, AOD services, to do infinity groups, where we've got kind of a purple and a green zone, and then the shared zone is a red zone where, there's, if there's an infection in one group, that we've got kind of keeping one part of the workforce that kind of safe, and we can kind of continue the services in that way. So we're looking at all different options, but again, it's going to be really site specific and service specific. We are in often older buildings and our services have expanded, where we're kind of, had opportunity over years to kind of make bigger rooms into smaller rooms. We've definitely got rooms that we can't provide a service in a socially distant way. So what do we do with those rooms now? They're all questions we're thinking about.
Just on workforce, and Ollie, I'll bring you, if I can bring you in a second. I just want to pick up on a point that Victor Billis has made, which I think is interesting, just in terms of working from home. That telehealth isn't exactly the panacea. Working from home isn't the be all either, because psychologically, and thanks Victor for your question, people do struggle to work from home, and it doesn't necessarily suit some people. So that future models need to allow for this flexibility. Molly, did you want to make a comment?
We, in our planning, we're thinking about perhaps doing a staggered return to the workplace, but not a full return of staff, where we may have, for example, 50% working from home and 50% on site, and alternate that, whether it's weekly or fortnightly. We haven't quite fine-tuned that plan. But there's some of the ideas we're thinking about. And in doing that, we would have a hybrid model of face-to-face and online platforms and digital platforms. But just to pick up on Leanna's point about the workspace, we're in a similar situation where some of our facilities may not meet the social distancing requirements. So that's sort of led us to think about only having 50% of the community services workforce on site at one time. There are other issues with infrastructure around counselling rooms that are not big enough to have 2 people in them, for example, similar to Leanna. But we're working through some, you know, artistically conceived ideas that where we can build a plan and connect it to an evidence base. But yes, I think people have all been very creative and collaborative and participating in a way that's generating some ideas that we have not thought of before, which has been terrific.
Can I just say on working from home flexibility and psychological impacts? I think this is really interesting. It's exactly the same as the telehealth conversation. It can't be all or nothing. So, and for me, you know, a lot of people are talking about, well, some people can work from home in the future and some people should work in. For me, it's like everybody should be able to do a bit of both. And it's easy for me to say because my particular workforce is a group of office-based people who, you know, go out on the road to visit members and all that kind of thing. So from my personal perspective, I get that we're kind of not challenged in the ways that a lot of people are, but we can still share learnings from that and saying, you know, because it's not just about working from home, it's about flexibility. So saying to people with caring responsibilities, no, you don't have to be logged on at home from 9 to 5 as though you were in the office. You can work around those responsibilities so that we're enabling you to work in a way that works for your life rather than for my kind of, I was as guilty as anybody else of being in the past, the one who said, oh, I like having my team around me because we can collaborate, and oh, are you sure they can work from? Can we trust that person to work from home? I sound like a right git, don't I? But that's what I was, and we all did it. Whether we're honest about it or not, we all did, and now we know that we were wrong. So the same as with telehealth for clients, it needs to put the power in the hands of the employee to be able to say, I like working this way, and I want to keep doing it, and if you're going to look at me like I'm lazy because I choose to work from home, that's not okay. Or if you're going to say I either have to be 100% at home because we've sold your desk, you know, hot desking is going to become a thing, even though from a COVID perspective, that's not great. But, you know, it's about power in the individual's hands.
Scott, the only other thing I'd add to that is that for the next few months, it's going to really require those workforces that can work from home to work from home, to enable those workforces that can't work from home, that can't perform those functions, to be able to then get them out and about and engaging with the people that need to be engaged with, both from our service perspective, but also from the economy perspective. So we know that not all functions can be performed remotely or from working from home. So it's going to take a bit of effort from us, and particularly for parts of our delivery environments or our, you know, policy office, back of office sort of environments that can easily manage things from a remote environment, to really enable those other people to be out and about, so that we've got that sort of mix and not having everyone get out and about, because that's just not going to work for anyone.
Thanks, Argiri. I noticed Nicole's talking, and maybe Nicole Pence has made a point on this, that it's about a mindset, that our mindset, in fact, this has been a cultural shift as much as anything else, and a mind shift, a mindset that's shifted and that needs to, in some ways, remain open, remain flexible, and challenge ourselves and our thinking going forward. Chris has got a question, Simon. I don't know if you've noticed that or can see that. Can you do outreach via telehealth? And what do you think will happen with sex on premises venues? If they don't reopen in the near future, do you think that they will be replaced with underground venues? And if sex on premises venues go underground, is that concerning? And I think there may be some relevance here. I mean, I'm keen to hear your response, but I think we can take this a little bit further into our drug using populations too, and thinking about how drug using populations use drugs together and that process. So Simon, can you talk about
Yeah, look, it's not really AOD related, but sex on premises venues, so we have a range of saunas and according to the federal government, bathhouses, because we're 1970s New York. But the sex on premises venues mostly hate me because I told people they shouldn't be going to them before they were told to close. And they were all arguing that you can socially distance, and they were only having 20 people enter at a time. And I said, but it sort of goes against the grain of social distancing when you're going to have sex with 5 people. They will probably be one of the last things to open, I'd imagine. You know, it took a bit of work to get the government to actually consider how they are different to bars and clubs. You are going there with the purpose of intimate physical contact, and there is no way not to spread the virus during sex. It's not a sexually transmitted virus, but there is no way not to spread it, essentially, if there's saliva involved. But yes, all of our services need to change. We're looking at moving everything online. I think one of the issues is we never realised we were going to be this successful. We thought this was going to be much longer, and who knows, we may not have another outbreak. We may completely buck the trend. And so for questions about do we spend a lot of money, we've just spent a lot of money on IT, like literally 50, hundreds of thousands of dollars on IT and upgrading and taking a lot of risks there. And do we redevelop physical services? Do we put lots of money into moving everything online when we actually may be back to normal in 8 weeks? Who knows? So I think there's a lot of questions about that, but outreach into those venues and things like remote HIV testing and sexual health screening, it's something that's very difficult to do remotely, but we're exploring it.
I guess my point was, or link was, to think about how people use drugs and social distancing for the most vulnerable users who are continuing to use and be together at that time. Any thoughts on that?
Well, you know, again, everything's moving incredibly quickly. I saw my first piece of drug research 2 days ago. The Flux study has released some figures. Flux is a study on gay men who use drugs in sex, and it has seen huge drop-offs in drug use. And that group already use drugs at a generally higher rate, a significantly higher rate than the general community, and it saw significant drop-offs across all drugs, but particularly cocaine, ecstasy, methamphetamine, and GHB. And if that's going to continue, and particularly if borders are closed and those drugs struggle to get into the country, we're going to have to look at all of our drug and alcohol services. This is going to be akin to when heroin disappeared and we had an entire service sector around one type of drug, and we suddenly all had to readapt to alcohol and cannabis again being the primary focus of our work. And, you know, if injectable drugs stop getting into the country, you know, what is the future of drug harm reduction programs and what are we going to do? So there's a lot of questions there, I think.
I am struck by how we as humans respond to crisis and adapt and change and consider our mindsets and the flexibility of us to do that and then to maintain that rather than return to old patterns or ways of thinking. Could I invite some last comments from...
Can I just jump in on that issue, Scott?
Please.
So, there's a bit of caution there for me, right? Because what we see in periods of crisis is that really roll the sleeves up, get in there, do what we need to do, make quick decisions, mobilise, and we see that in emergency events time and time again. And people are sort of astounded quite positively by the rate of decision making, the pace of it, and how quickly we can mobilise, both from government, community services sectors, and from our community more broadly. But equally, we revert to form very, very quickly. We always revert to form. And that's the point of caution, I think, for what this pandemic and its effects, because it is unprecedented, certainly in terms of a scale and its impacts. And the last thing we want to do as we eventually, whatever time frame that looks like, come out of it, is to revert to form, because we'll have lost all those opportunities that potentially can be realised to create a new norm going forward. And I think that's the challenge for government, because government is equally happy to pivot back to a way of doing things. It's a challenge for our community services sectors. It's a challenge for our workforce. So we have to in many ways, we're going to have to lead this, and we're going to have to be very disciplined about what we take forward out of this.
Thanks, Argiri. What I might do is hand back to Andrew, but just in the process of doing that, I'm going to pick up on a comment of Stefan's around that, in fact, the AOD sector and our history of harm reduction has something to offer the broader community health service sector, if not wider again, as opposed to an abstinence or black and white lens. I think it's a really nice point from Stefan. Andrew.
Thanks very much, Scott. And I think you did an excellent job of chairing the panel. And thanks very much to all our panelists. In particular, thank you to Argiri and Tom for your very thought-provoking and detailed presentations, and then follow-up participation with our panel. Really appreciate it on behalf of VAADA and the whole sector. Just to remind everyone involved in the webinar that the next webinar in this series will be held next Thursday on the 28th of May at 10:30 this time. And you can check eNews or the VAADA website just to confirm. So thanks, everybody. I think it's been excellent, and very proud to have chaired this forum. See you again soon. Bye.
Cheers.
Thank you.
Bye, everyone.